Hello, my name is Dr. Anand Khakhar. I am a senior consultant surgeon and program director at the Center for Liver Disease and Transplantation in Chennai. And we are among the leading multi-organ and multi-visceral transplant surgery programs in the country. It has been our endeavor to bring about the latest and the best that is available for end-stage organ failure and patients suffering from liver cirrhosis, kidney failure, pancreatic failure, kidney failure because of diabetes, and bring a solution to their maladies. And it is a part of this endeavor that we initiated the first viable pancreas transplant program in this country. And joining me here today is my colleague Dr. Vaidya. Dr. Anil Vaidya has served as a lead clinician and the senior most consultant surgeon at the Oxford University Medical Center. As a part of his passion to serve patients with combined diabetes and kidney failure in our country, he has decided to leave Oxford and join us in our endeavors at Chennai. So, Dr. Vaidya, what would you say about the challenge of diabetes and kidney failure in our country?
Diabetes in India, as you know, is rampant. What we know of diabetes and the numbers, we think there are about 90 million diabetics in this country that have been diagnosed. We do not know how many have not been diagnosed, of which 10%, that's about 9 million, are type 1 diabetics. It is a huge number, and what we need to also understand is how are we going to cure this disease, not treat this disease.
Correct. That's very important. The emphasis on cure rather than
treating the disease. So when you treat diabetes, you're treating it in a chronic fashion. You're addressing their requirement for insulin. However, you haven't addressed their biofeedback requirement for glucagon when your sugars go down. So this is something that can be done only with an endogenous source. So that's where your pancreatic transplants come in a big way. The insulin independence rates are very high with pancreas transplants, but not everybody requires a whole organ pancreas transplant. We've shown this in the West, we've shown this in Oxford, one of the only 2 islet isolation units in the UK, that there are a certain group of patients that will benefit from what is called as islet cell transplants, where you take the islets from this whole organ pancreas, you process them in the lab, you get an aliquot of islets, and then you infuse these islets into these patients who are then, we try to get them insulin independent. However, some may not get insulin independent, but they would benefit from the islets by extending their lifespan because they get into euglycemia. That means their sugars stay normal for a certain amount of immunosuppression, but not a big operation like a pancreas transplant. I was surprised when I first came here 2 years ago to see that there wasn't a single laboratory in India that was looking forward to pursuing islet cell transplantation. There has been efforts, I think, a few years ago, but these were different animal models, but no one has taken that step into the right direction for human islet cell isolation. The techniques are quite robust. It is not an experimental procedure anymore. The United Kingdom, the European Union, Australia, all of these centers in these places are doing islet cell transplantation as a clinical program. The first one, as we all know, was done in Edmonton. This was in the early 90s in Canada. And since then, there's been so much of development on this islet cell field that it has taken us from what was once an experimental procedure to a therapeutic procedure right now. And I think in India, we can serve a lot more people with an islet cell base rather than going for a whole organ transplant.
So just 2 or 3 things I would like to clarify with you is that, one is that when you said about the superiority of pancreas or islet cell transplants over the mere administration of insulin, I understand that not only the feedback loops are superior with the transplant versus insulin, but also the transient peaks of hyperglycemia, which leads to end organ damage, which may ultimately compromise the quality of life as well as the longevity of these patients, could be prevented by either a whole organ pancreas transplant and equally so by a islet cell transplantation.
You're absolutely right. This is what causes the end organ damage. That is the high sugars. Once you can prevent those high peaks of sugars and keep them in what we call as a euglycemic range, you certainly add on value add years to these people with diabetes. There's no question about that.
And one more thing I wanted to clarify is that this translational research that we are talking about at this point, something that has been done somewhere, but we need to reproduce the same results, the same methods, the same technology in our country, is something that is going to be done in a non-commercial fashion, so that this is a technology that will be made available to the people of our country. And as I believe, not just our country, but the entire Southeast Asia does not have a single islet cell isolation facility, and therefore this technology, once if it can be replicated in our setup, could potentially benefit hundreds of crores of people, millions and millions of people.
The thing is, before you put your definitions in place, every center that has started an islet cell lab, it is important for that center to demonstrate that they can consistently isolate viable islets before starting into a clinical program. This has been the norm for every center around the world. So we're not doing anything different. And we're calling it translational research, but it is really not research. It is just checking on our abilities to follow protocols that are already in place, accepted worldwide, and how can we put them in place with us. Not only to be confident with the new team that's being formed, but also to make sure we do not put any patient at harm, at risk, when we start that islet cell transplant program. So it has to go through these two phases. The phase one would be, you look at how many islets per pancreas can you isolate. Are they pure enough? When I say pure, it's not because of being infected. Pure means, are they pure islets? Is there anything else that's coming in with the islets? Is our purification process not good enough? Do we need to improve? So these things have to be answered much before you start a clinical program. And this has been the norm, as I said before. Oxford did it, Edmonton did it, the programs in Europe did it. So it is a normal progression from not doing anything to an islet cell program, clinical program. It has to go through this first proof of concept phase. So I would be hesitant to call it a research project. I would say it's a stepping stone to finally delivering islet cells that will be therapeutic and will help people get off the need for insulin.
Thank you, Dr. Vaidya, for clarifying these points. Thank you very much.